Welcome everyone, and welcome to our grand round on peer navigation in cancer care. My name's Jerry McDonald. I'm the Director of Patient Experience and Wellbeing and have been leading some of the work in this area. I would like to start by acknowledging the traditional owners of the land on which we're meeting. I'm at Peter Mac in Parkville, which is the lands of the Wurundjeri people of the Kulin Nation, and I pay my respects to their elders past and present, and I extend that respect to any other Aboriginal and Torres Strait Islanders here today, and we have a number of people online. So I think I'll just start with, no, not yet. I'll start with just a bit of a definition of what peer navigation is. So today we're going to be showcasing the work we're doing in peer navigation here at Peter Mac, and we're defining peer navigation as a person with a lived experience who's undergone some training and has been matched with someone with either a new diagnosis or a similar diagnosis. The purpose is to provide support and assistance in navigating what we know is a very complex, busy system. So today you're going to hear from one of our mentors, Brett, who will share his experience. We're thrilled to have Associate Professor Jackie Bender here from Princess Margaret in Canada. In Toronto, you'll know that Peter Mac has a very important partnership with Princess Margaret, which involves a lot of this education exchanges. So it's great that we managed to score Jackie while she was visiting for another reason. And then we have Associate Professor Rebecca Jessup, who's our partner in peer navigation at Northern Health, and Brett, who's one of our peer mentors. Just on the term peer navigation, we've sort of had a number of discussions of this at Peter Mac, where there's concern around confusion over the patient navigators and peer navigators. So when we refer to our peer mentors, it's the patient navigators, not our PAT navs, but our peer navigators. So I'd like to introduce our first speaker, Brett. Brett Alpern was treated at Peter Mac for head and neck cancer in 2022. And he's recently joined our new peer mentor program as a volunteer peer mentor. So Brett's going to talk to us about his personal experience during his cancer journey and supports that made a difference. So thanks, Brett.
Thank you. Hi, everyone. I'm Brett. When I was thinking about what I would speak to you about today, I realised very quickly I was never going to squash the whole package down to 5 minutes, which means I guess you'll miss out on some very funny stories. What I will be talking about, though, is I did want to reflect just a little how for some patients, and that is, of course, people like me, speaking with someone who has lived experience can make actually a huge difference. First, a little bit of background. My parents always joked that I was the sort of kid that wanted to know what was going to happen before it happened, which I expect was infuriating for them. However, as an adult, what that means is I like to prepare myself for things that might be coming. And so it was with cancer. I wanted to know the possible trajectories of my treatment as best as I could. I wanted, obviously, to know the range of possible side effects I might experience. I wanted to mentally prepare myself for what might be coming. That was and still is my way of managing stressful situations. Not everyone's like that. Some people don't want to know, but I do like that. Now, in my case, I was diagnosed with a HPV positive squamous cell carcinoma. I had a secondary tumour on the side of my neck. The primary was, actually they never found the primary, which is hilarious. They call it an occult primary, like, you know, the supernatural. And so I imagine my radio oncologist, some of you will know him, Sien Fua, with a Ouija board, trying to map out where on earth the cancer is. This is the stuff that goes on in cancer brains when they're in the middle of this. I had the usual for this type of cancer, 7 weeks of chemo and 35 rounds of radiotherapy to the neck and throat. Left side copped the full kind of roasting, and this side copped about 2/3. And now, being completely serious, it was the hardest thing I've ever had to do in my life. But that said, after speaking to numerous head and neck patients, I reckon I got off super easy. Now, my radio oncologist and indeed all the treating team, they were fabulous. They did a great job of sort of fueling my need to know, balanced with, not giving me too much information so that I wouldn't kind of freak out. But without a doubt, one of the most useful interactions I had was with a past patient. He had the same cancer as me, in almost the same location, and aside from, I believe, the chemotherapy regime, pretty much the same treatment itself. Now, he didn't tell me what to expect or what to do, but instead gave me the opportunity, or the space, if you like, to ask him about his experiences, which he graciously shared. But also occasionally he would remind me that, my experiences aren't necessarily going to be identical to his. Obviously, two people, same treatment. We all come with our physical and mental histories and pasts, and respond very differently to even the same treatment. Now, a little bit more about that exchange. It was a comfort on a number of levels. One, because I got the information that I was craving, but two, on a kind of a more personal note, and I suspect I'm not unique here, I was pretty scared about what was coming, and while it's a little awkward to say out loud, but the thing that I was the most scared of, or the most fearful of, was that I wouldn't handle the treatment, or I wouldn't cope with the treatment in such a way that made my family proud, which is, it's kind of a weird thing to say. On the one hand, that's very human. I can see that in myself. I get that. But on the other hand, it's patently ridiculous, because it's not a test that I have to pass. I'm not going to fail it for my family or anything like that. But again, this is the sort of stuff that when you're in the middle of it, that you toss around. But speaking with him, he had lived experience with what I was going to go to, made it easier. I actually called him twice, once at the start of treatment, which was great, but then critically once more at about the 3 to 4 week mark, when I don't know if many of you know the trajectory, but some of us have to have a nasogastric feeding tube. In my case, I couldn't eat, I could barely drink, and I knew in that way, your own body, that I was standing on the edge of a precipice. You could just feel that the weight was about to come off, and I didn't want to do this. I was quite fearful of it. And looking back, that decision and the few days after that decision, coming to terms with that, that was the lowest I was in the whole treatment, even when physical stuff got heaps worse later on. Mentally, that was really hard. But speaking to him, which was only a very small thing for him, and probably the specifics of the conversation might be something that he may not even remember in detail, that was a massive, like a huge comfort to me, and helped me more at that stage of my treatment than any clinician possibly could. Hands down. In conclusion, in my view, peer mentoring is not for every patient, nor should it be, but for some patients, people like me who want information, who are calmed by a little bit of knowledge, it's actually everything, because it helps us take back just a little bit of control. And I don't know if many of you are aware, but when you're going through treatment, your path really narrows. Everything is very narrow. And so something that gives you this much extra actually can make a huge difference. So yes, I'm a huge supporter of peer mentoring, and thank you for inviting me here today.
Thanks, Brett. It's so important that we have this lived experience and learn from it. And we're very lucky to have you as one of our peer mentors. And Brett has been matched with someone and has met someone already. So as I said, we're very lucky. So I'd like to introduce Jackie Bender. Jackie is the Associate Professor who is visiting from Princess Margaret Cancer Centre in Toronto, Canada. Jackie is a scientist in the Cancer Rehab and Survivorship Program, co-lead of Equity, Diversity and Inclusion in the Department of Supportive Care, and co-lead of research for navigation at Princess Margaret. Jackie is also Associate Professor at the Dalla Lana School of Public Health at the University of Toronto. And Jackie has an innovative program of research in digital health and cancer survivorship that aims to improve access to care and promote health equity. So we're thrilled to have you here today, Jackie.
Thank you so much, everyone. I'm so pleased to be here. I'm just going to grab some water. I'm so pleased to be here. Thank you so much for the opportunity. As Jerry was mentioning, I'm going to be spending some time in Australia to do some collaborative work with some colleagues. So I just flip forward.
Yeah, just use the arrow.
Yeah, perfect. And was really pleased when I had the opportunity to pop here to Peter Mac. It's been a while since I've been in Melbourne, and certainly haven't seen this gorgeous facility that you have. So really grateful to Fiona for the tour this morning. So I'm going to dive right on in. I want to take a moment to acknowledge the land where I'm from and also where I conducted this work. So the University of Toronto and the University Health Network sit on the traditional land of the Huron-Wendat, the Seneca and the Mississaugas of the Credit. And this meeting place is home to many Indigenous people from across Turtle Island. And I'm very grateful to live and work on this land. This is a photograph of Toronto. We have this great big lake, many lakes in Canada, and that's Princess Margaret and the University of Toronto. But not so long ago, this was Toronto in March, just a couple weeks ago. So we went from several very large snowfalls, went out skiing, did a lot of shoveling, to the totally different weather in Cairns, gorgeous, lush, hot, humid, very different climates at this time of the year in these different parts of the world. So the Princess Margaret Cancer Centre is the largest comprehensive cancer centre in Canada. It has 14 disease site groups and over 18,000 new patients and over 600,000 visits annually. It has a strong clinical research program with over 23% of patients participating in clinical trials. And we essentially have 4 pillars of care: surgical oncology, radiation oncology, medical oncology, and supportive care. I realize I'm far from the mic. Can you still hear me okay? We're going to come a little bit closer. And I work in the Department of Supportive Care. So the Department of Supportive Care is a very multidisciplinary department. We have over 171 individuals, clinicians, researchers, allied health. And this, our department has 3 core divisions: cancer rehabilitation survivorship, of which my core division, palliative care, psychosocial oncology. And then across these 3 divisions, we have a lot of overlapping specialty programs, 7 overlapping specialty programs, as well as 2 adjunct programs. I started work in navigation predominantly because it was becoming quite apparent to me that patients and their family members had a lot of unmet supportive care needs that extended well beyond treatment. And a recent report by the Canadian Partnership Against Cancer revealed that on average, about 55% of patients are not referred to psychosocial services or programs when presenting with anxieties and fears about treatment. So they're not aware these programs exist and they're not being referred to them to address those supportive care needs. Navigation in Canada and many parts of the world, innovations in navigation in particular, as well as innovations in virtual care, are seen as critical to enhancing person-centered care delivery, improving access to care, and addressing disparities in care. And so because of that, I became very interested in exploring how we could leverage navigation as a tool to address the unmet supportive care needs that we were seeing in patients with cancer and their caregivers. So patient navigation is fundamentally a barriers intervention. So what I mean by that is patient navigation aims to, first of all, assess needs, identify any barriers to getting those needs met, and work with the individual to alleviate those barriers to address those unmet needs, with the goal of improving access to care and reducing disparities in care. The first known navigation program was actually created by Dr. Harold Freeman in Harlem, New York, for African-American women with breast cancer. There were low rates of breast cancer screening and high rates of late-stage diagnosis with that group in that region, and he created this lay peer navigation program to address that. It was enormously successful, and as a result, many patient navigation programs emerged across the US and in Canada. Since then, several systematic reviews, including an umbrella systematic review conducted by colleagues here in Australia, have demonstrated that patient navigation can increase screening rates, can reduce time from screening to diagnosis to treatment, can improve patient satisfaction and a number of survivorship outcomes that I've not listed here. And there's also evidence that suggests that it can reduce healthcare costs, at least in the US, but I'll be presenting some data from Canada that shows that it does work in Canada as well. There are many different models of navigation that exist, different people in those roles, and they use different communication technologies to conduct their work. In general, there are three main models. There's the lay or peer model of navigation, and that's a lay person, or a peer, which is someone who has had cancer, and they can be either paid or volunteer. There's the healthcare professional model, which is usually a nurse or a social worker in that role. And there's the hybrid that brings the lay peer together with the healthcare professional. With respect to Canada, the vast majority, with many navigation programs across the country, most of which are led by nurse navigators at point of clinical care. And in terms of delivery models, most navigation programs involve in-person navigation or telephone-based navigation. There's really a striking lack of the use of technology to support navigation. And in fact, the umbrella review of systematic reviews of patient navigation really highlighted that was a missing gap in the literature. So I became quite interested in the role of peers as navigators, and there are a number of advantages to having peers in these roles. First of all, peers have the opportunity to provide that authentic empathy coming from really understanding what it's like, and you can really skip a number of those steps to building those relationships because of that. Engaging racially matched, geographically matched, linguistically matched peers is really effective in reducing disparities in access to care. Engaging peers who are cancer survivors as navigators benefits the cancer survivor because it leverages their desire to give back and it improves their psychosocial well-being. The hope is that by reducing these supportive care needs, we're reducing visit capacity, and peers or volunteer peers, paid or volunteer, are certainly less costly for the healthcare system than a nurse or a social worker in that role. And importantly, many studies, including studies I've conducted myself, have demonstrated that cancer patients and caregivers really value being connected with other people who know what it's like, who've been through the experience and guide them. There's also a number of benefits to using technology to support patient navigation. First of all, it really streamlines onboarding. There can be a lot of self-selection into that onboarding, which removes the need for personnel at that time point. It facilitates matching based on patient preferences. We can leverage, as you'll see, algorithms that support the matching of patients with peer navigators. It offers multiple modes of communication. It also consolidates education materials and that information that navigators are looking for to link people to relevant programs and services. That often is one of the most time-consuming aspects of the navigator role, consolidating all this information and staying up to date on all this information to navigate people to relevant programs and services. Streamlines navigator workflow, as well as report documentation, and also provides an opportunity for ultimate integration into EMRs with the hope that navigators' notes would then be available for the clinical team to view. So knowing all of this, I, with funding originally from Movember here in Australia, designed a digital peer navigation program. In its original form, it was known as True North Peer Navigation, and that was in part because the funding came through Movember and their True North program. I've since rebranded and adapted it, rebranded it as Peer Nav and adapted it for other cancer types. But essentially, it's a digital navigation program that matches patients and caregivers with a volunteer peer navigator who is trained to help them get the care and support that they need. A peer navigator is someone who has experienced cancer either as a patient or a caregiver, and peer navigators essentially have three main functions. So as a reminder, this is a real sort of barriers intervention. So first and foremost, they need to assess needs. When patients and caregivers come into the program, they have to complete a needs assessment. Navigators then review that needs assessment and use that as the sort of benchmark basis from which they support them over a period of at least 3 months and help them to overcome those barriers to care. They provide that much important and valuable support that no other person who's not gone through it could provide, and that's the informational emotional support from a peer. And then most importantly, the empower proactive approach to health, because of course the navigator can't be with the individual for forever. So the goal is to impart that knowledge, skills, and self-efficacy to act as their own advocate and navigator and support themselves navigating the system. And if we have time, this is a, oops. This is a short video. So brief overview. So Peer Nav essentially has three main components. First and foremost is the Peer Navigator training program, which I'll talk a little bit more in detail, but it's a competency-based training program that all individuals must complete. It's an 8-week program, quite comprehensive, to become peer navigators. And then we have a peer navigation website and app, and this app facilitates onboarding, matching, offers multiple modes of communication. It prompts and provides opportunities for patients and caregivers to complete assessments, for the navigators to review the assessments. There's this resource library that we've created, as well as a suite of case management tools for the navigators. And then we have peer navigator support in the form of a clinical supervisor, either a psychologist or a social worker, who leads monthly debriefing meetings where individuals discuss their cases, also provides one-on-one support, and then we have regular check-ins and can monitor their reports that they complete in the app. So we began first and foremost by establishing the core competencies for the role, which is really important to create boundaries around the scope of practice and delineate and differentiate it from other similar roles. And so we identified 47 core competencies that map to 6 domains that were required for the peer navigator. And we went through this exercise of verifying and endorsing those competencies with navigators and other content experts. We then used that competency-based framework to design this training program. So this is an 8-week training program that consists of 8 educational modules that are mapped to these core competencies. The goal is to build knowledge and self-efficacy for these core competencies. It's a very interactive online training program where there are cases, polls, role plays, facilitated discussion. They go through each module in a learning management system. We use Moodle. At the end of each week, we have a synchronous session led by members of my team. I'm one of the instructors as well, or we bring in guest experts, such as those with motivational interviewing or expertise in EDI. These are the core curriculum components. As you can see, we spend a lot of time using motivational interviewing informed communication skills. This isn't an MI intervention, but we do teach a lot of MI informed communication skills, which we find to be really effective. We've also evaluated this training program and have shown that that navigators were highly satisfied with this online training program, and it was effective in increasing navigator self-efficacy for all core competencies across all 6 domains. And I thought I'd show you a photograph of some of our peer navigators. We meet monthly online. And so this is a collection of some of our prostate cancer and head and neck peer navigators. In total, I was just asking my team, and I don't have the numbers, but maybe as I look at some emails when we have discussion, I can tell you the total number of trained navigators we have. We've trained a total of 50, and I just can't remember how many we have active right now. Probably around 40 is my guess. So how does it work? Patients or caregivers essentially log into the app. They answer a series of questions about themselves, as well as complete a needs assessment based on the series of questions they answer. The algorithm turns them up navigators that are similar to them based on certain characteristics such as age, cancer, gender, ethnicity, sexual orientation, depending on their preferences. They then get to choose the navigator. They look at the profiles, choose the navigator they want to work with, and then they communicate with that navigator through the app, through direct messaging, through video conferencing or telephone. And then the navigator has this dashboard of features that they use to manage their cases. And then there's this resource library, which patients and caregivers can access themselves, and the navigators can go in and send resources to them as well. So we've conducted a pilot study of this program in prostate cancer, and it was found to be highly effective. Participants were very satisfied with the support they received from their navigator, and we found significant improvements pre-post, this is a pilot, in patient activation and quality of life. Participants explained that it filled a gap in care and that optimal matching was key to patient satisfaction. This is an example quote. He was really a very good match. He had very similar surgeries and treatments, and his personality and approach and helpfulness was just particularly good, sensitive, and supportive. I couldn't have asked for a better match. So optimal matching is quite key. I mentioned that it did increase patient activation. Patient activation is a really important patient-reported outcome that's associated with a number of health-related outcomes. It's having the knowledge, skills, and competence to manage one's health and access healthcare. And it is identified as a core outcome of navigation and a desired outcome from patients and caregivers who are being navigated. So with the positive results from the pilot study, we then got some funding from the Canadian Institutes for Health Research, which is our largest research funding body in Canada, to conduct a multi-province randomized controlled trial of the peer navigation program in Ontario, British Columbia, and Nova Scotia. And the goal was to explore the impact of peer nav in men after treatment for prostate cancer. So I was trialing it as a post-treatment survivorship care initiative on patient activation, a number of secondary outcomes, as well as on fidelity, cost, and I can see its cutoff barriers and facilitators to care. And they were randomized to the intervention or an active control. The active control was the resource library in the app. So they had access to the exact same resource library the control group did, and only that, nothing else. But it was waitlist, so after they completed their questionnaires in the control group, they could be offered a navigator if that's what they were interested in. And so we found that the peer nav was highly effective. There were significant improvements in the primary outcome patient activation. This is general linear model that's controlling for baseline differences. And there was a significant increase in patient activation in the intervention group and no change in the control group. So that web-based active control had no impact on their patient activation. We also found significant improvements in quality of life, particularly we use the EQ5D to measure that. That's a 5-dimension measure. And the dimension that showed the most change was actually anxiety, depression. So I think most of the change we're seeing in quality of life is a reduction in anxiety and depression. On a separate patient-reported outcome measure, the PHQ-9 depression, we also showed a significant improvement. And then overall, people were reporting fewer supportive care needs. So this intervention was essentially meeting their supportive care needs. We also investigated whether or not this program was cost effective. And so we used a Markov model and to explore the quality adjusted life years that were associated with incremental improvements. And we found that using patient activation measure, there are 4 patient activation measures, 4 patient activation states within the measure, and a death state. And we found that peer nav has an incremental cost effectiveness ratio of just over 9,000, which is well below the willingness to pay threshold of $50,000. Per quality adjusted life years. And we conducted a number of sensitivity analysis by changing up a bunch of stuff to see whether or not it was still cost effective, if the time horizon was different, if there were no maintenance of effects after the 3 months. And we found that 55% of the ICERs, this is the scatter plot, were still cost effective. And so to wrap things up, I just wanted to let you know where we're at. So peer nav has been recognized as a leading practice by the Health Standards Organization in Canada. I was really pleased that we got that status. And we have expanded. So we started in prostate with some funding from November. We then started to do some needs assessments to explore whether or not peer nav would be suitable for adolescents and young adults with breast, sarcoma, lymphoma, and testicular cancer. And then we started to do some needs assessments head and neck. and then did an RCT in prostate. We're doing an RCT in AYA, and we're doing an implementation study in head and neck cancer. And we're just starting an adaptation study to explore how to optimize the intervention for patients and caregivers with advanced or metastatic cancer. And I wanted to also point out that navigation is a priority at the Princess Margaret Cancer Centre, and I've been part of the navigation working group that has been working together to create a navigation strategy. And so PeerNav will soon become part of routine care, and offering as part of routine care, peer and lay navigation. So everyone will be encouraged to participate in self-navigation. Everyone will be offered lay or peer navigation, as well as point of care navigation. That's your point of care navigation, the navigation you'd be receiving from healthcare providers. After triage, following subsequent patient assessments that are going to be happening continuously, that may then navigate people to either more enhanced clinical navigation, depending on their need, or specialized navigation, depending on their need. And then lastly, we are working to identify a scope of practice internationally. Most of the work to date has really been done in the US and Canada, but there's a growing momentum in Australia that's very interested in navigation. So working with colleagues such as Dr. Ray Chan from Flinders University as part of the GENO initiative. This is the global initiative to advance navigation outcomes. And the goal is to identify, to describe, and come up with this international practice framework, test some quality indicators, and then develop an implementation guidance, implementation toolkit and guidance to optimize navigation internationally. And that's it. So thanks everyone for your time. Look forward to the panel.
Thanks, Jackie. I don't know whether I should be disheartened or relieved about the timeline. So, you know, we've been trying to get our service up here for greater than 5 years. So it's kind of nice to see that your timeline, you're at 11 years and you've done all the work for us. So thank you. So I think we'll hold off questions until the panel. So now I'd like to introduce Rebecca Jessup. So Rebecca's Associate Professor and the inaugural Director of Victorian Centre for Virtual Health Research. Rebecca's completed her PhD in health literacy in 2018, followed by a postdoc fellowship with Monash University Department of Clinical Epidemiology in 2019. Rebecca is passionate about ensuring individuals receive the right care at the right time, in the right place. And to this end, her research has included virtual and telehealth models of care, health literacy and communication, health equity and alternative models of service delivery to improve access, outcomes and health system sustainability. Thanks, Beck.
Thank you, everyone. And they are two very hard acts to follow, so I hope I can keep you entertained for another short 10 minutes. Just want to also acknowledge the Wurundjeri people of the Kulin Nation on whose land we're meeting today, and to extend my respect to their elders past, present and emerging, and to acknowledge that sovereignty was never ceded. It might seem a little bit strange that a director of a virtual research centre is talking about virtual centre for health research is talking about human peer navigators, but I also lead all our peer health navigator work at Northern Health because I'm incredibly passionate about it. I think it is potentially the solution to addressing barriers to care and improving equity across our populations. I want to acknowledge my two very, very hardworking colleagues, Simone and Hanifa, who are in the audience today, who really, I wouldn't be able to get any of this work done without them. So thank you very much for all your work and support all the time. We're not going to talk too much about the definition of peer health navigators because we've really touched upon this already, but to say that they really do provide that bridge between clinicians and community members, and they really are improving trust that has broken down often with some of these communities. So they're a really essential role that we really need to be implementing in Australia. As Jackie's already mentioned, there is a growing body of international evidence to support the role of peer health navigators, and they have been shown to improve patient engagement and satisfaction with care, improve health outcomes, particularly in chronic disease diseases, including cancer, to reduce health disparities for populations like First Nations, culturally and linguistically diverse, and for people living rurally and regionally who have the tyranny of distance and access issues are associated with that. They are important for advocating and coordinating care, overcoming issues of distrust, as I mentioned, with health systems that sometimes leads to avoidance and non-adherence to therapy. And they have been shown to be cost effective, as Jackie has said, and we've recently completed a propensity score matching exercise, and it wasn't in cancer care, it was looking at patients who have repeated presentations to emergency and repeated hospital admissions. So the patients who are considered to be the most costly for the health system at the moment, who have really chronic and complex conditions and keep bouncing in and out. And we identify them via an algorithm and provide them with health navigator support using a decision support tool, and they're supported by health professionals that they can pass any concerns along to, and they can help them navigate the system that way. And we've actually found that they have halved the number of presentations, halved the number of admissions, and halved the number of bed days when people are admitted. So we actually believe that proactive management means that these people might actually need admissions, but when they do have to have them, we've caught them earlier, they don't need to stay as long. And so their experience of care is better. People don't want to be in hospital, they want to be at home with their loved ones. So their experience of care is better, and the health system actually saves money because of that. So these are very early studies we're doing in Australia, and as Jerry has pointed out, we are at least 5 years behind Canada, probably 10 years behind. We've got a long way to go in terms of catching up. And this is important because the WHO came out with a policy paper in 2022 saying there is really good international evidence for these roles, but that systems and settings really differ across countries. And so you need to create the evidence within countries. And so that's what we're trying to do. And that's the work I'm going to talk about that we're doing with Peter Mac in a minute. But it's interesting because there are a number, even though we don't have a lot of evidence in Australia yet, there is a number of peak bodies that are really saying we need these roles. And one of them is the Australian Cancer Plan, which has identified that we need these roles to improve equity in cancer for some populations and within some cancer groups. And importantly, I really like this comment from a consumer in the public consultation submission, where they've said most cancer patients are not worried about having the latest surgery or drug. What they are worried about is having good, supportive, communicative, sympathetic, understanding care that includes primary care providers as well as other providers. And I think this actually speaks to the divide that exists between clinicians and consumers or patients that we're trying to bridge with these roles, because clinicians often, there are structural barriers for them in terms of providing that medium to long-term support and building those relationships. Sometimes there's a hierarchical structural barrier around clinicians being clinicians and patients being patients that is quite hard to overcome. And I really love that empathetic advocacy, or that Jackie referred to, that actually being someone of lived experience, we're not, as clinicians, we haven't experienced it, we haven't been through it, so we're not the friend that often these patients need in order to feel like they're heard and that they are understood. So I really think that these roles are an essential component of the health system that we've been missing for a long time. Is our health system complex? Hands up in the room if you've had problems navigating our health system. I actually think this diagram's pretty kind, really. It looks relatively straightforward from this diagram, and in fact, it's really complex. We have different layers of government that provide different levels of funding for different types of services. We've got primary care, we've got hospitals, we've got private health. We are encouraged to take out private health insurance, and that's we've got tax rebates associated with that to encourage us to do that. We've got GPs, which are not a familiar concept to many migrant populations who don't have general practitioners, who don't understand and often see them as a barrier to accessing the care that they need. It's a really, really complex system, and that's why we need peer navigation programs. And this work that we're doing with Peter Mac that I'm really, really excited about, we received a Victorian Medical Research Acceleration Fund grant, which allowed us to start exploring implementation of these roles across both Peter Mac and out at Northern Health. And we're not a cancer-focused hospital, we're a general hospital. So actually looking at the success of the roles across those two organisations and how they differ and what worked and what didn't work. So it's implementation research. We want to understand what the barriers are, how people are finding using these relationships to navigate health systems, and then we're going to use that to create an implementation toolkit, which is very similar to what Jackie was talking about, so that perhaps we can implement these in other hospitals across Victoria and nationally. So we're pretty excited about it. We do have really tight timeframes in which to deliver this, so let's see how we go. But we have luckily started or happily started matching patients with their lived experience peer navigators. So that's really, really exciting. And we're already hearing that from corridor conversations that people are finding it a really, really helpful and valuable service. So that's really exciting. There are a number of implementation challenges in Australia, and we published this article last year mentioning or talking about some of them. One of them is the inconsistent language, and it's a challenge. As Jerry said, we've had to call them the roles peer mentors here because the peer navigation role's been applied to another role. But across Australia, we have various roles that ultimately do the same thing. We've got care connectors, we've got peer navigators, we've got even the Aboriginal liaison officer roles are essentially people with lived experience who provide a connection with community. We've got we've got lived experience workers, peer support workers. There's probably a dozen different titles that we have for the same type of role, which means that we don't have any kind of national perspective around who's doing these roles, where and for who, because we are labelling them differently, and we can't get any kind of economies of scale because of that. So there's a real need to move towards a shared language for these roles. We don't really have any method for understanding and recognising the skills that these individuals bring to the roles and to help with training. So there's no defined method for training them, but we are doing some work on that. So we actually have developed a vocational education training package that we co-designed with people with lived experience, having worked with peer navigators and who also had complex and chronic conditions that would benefit from having a navigator, as well as clinicians, because we know that clinicians can be anxious about these types of roles and worried about people overstepping boundaries. So we need to bring the clinicians on the journey, because patients won't want to work with peer navigators if clinicians say it's not a good idea. So everyone needs to come along on the journey together. So we've co-designed this. We developed it with Swinburne University of Technology and Medibank Private, and we delivered it to the Department of Health last year, and we're hoping that they will make it available for vocational education and training providers to allow us to develop a workforce. And we think this will actually overcome some of our funding barriers, because one of the issues we have in public hospitals in Australia is that we're activity-based funded. So we get our funding based on a patient seeing a health professional, and that encounter is counted and we get some dollars for it. Now, because peer roles are not yet recognised as a role in the health system, we can't get that activity counted as part of our funding. We've actually had some conversations with the Department of Health, and they at the moment are allowing us to activity-based fund one of our peer navigation programs at Northern Health as a bit of a trial, and so we're pretty excited about that. But we do think that if we can get people through this vocational education process, that we'll actually be able to then start to argue that they are a recognised, qualified workforce, so therefore we should actually be funding it. And then that obviously it's the inadequate funding. So a lot of the roles that are currently employed across Australia are in short-term, vulnerable funded roles. And for this population, where sometimes we're actually engaging, so there's peer navigators in refugee and asylum seeker populations that are working with their communities. They're a vulnerable group. Most peer navigators are working in a vulnerable they're a vulnerable group, and we need to make sure that they have secure employment and that they're recognised for the work that they do. Okay. So at the moment, we're also working on a capability framework, and Jackie, I would love to talk to you about this and maybe get you involved in it, because I think it probably has some international application. So this is a capability framework versus a competency framework. So it's not about how we measure skills in a workplace, but it's about the skills and attributes that people have and that systems have to have in order for these roles to succeed. So at the very central to the role to success is that we want peer navigators who have personal characteristics that are going to make the role work. So they're empathetic, they're problem solvers, they are good with working with people and likable and all the things that make somebody engaging. But they're also someone who has lived experience, whether it's from living in a community and speaking a language and understanding the values and beliefs of that community, or whether it's someone who's had cancer and you've got lived experience of the process of going through cancer, or you're a mother with a child with a disability and you've been navigating the health system for that child or the National Disability Scheme for the last 10 years, and you can help other parents to navigate it for their child. That's lived experience comes in a variety of forms. You could be a carer for someone. So that's the second essential part to this role. Then there's the formal skills, which we hope we can cover by having this vocational education package. So the things we can teach you, which are things like motivational interviewing, human rights, working with diverse groups, understanding yourself and your reaction to situations. So one of the challenges for people who are in these peer roles is that they might come across situations where they feel, where it triggers emotional reactions for them, and how do they deal with that, and how do they work through that, and how do we make sure that we support them, which brings us to the next level, which is around our responsibility as organisations to ensure that we properly support and mentor and provide the right scaffolding around these roles in order for them to work. And then at the very top is about having funding and regulation and recognition at a national level that these roles are going to be part of our health system and that they're here to stay. So I just wanted to finish by telling you a little story about some of the navigators we have working and why they're so important. So cancer is a very new area for me to be exploring, and our previous work has been very much in the bicultural health navigation space. Northern Health has a population that is about 40% born overseas in countries where the language is not English and where they don't have necessarily the same values and belief systems that Australian-born might. And we really saw during COVID that there was a huge breakdown and a huge divide. We weren't able to get a lot of our community vaccinated, and our hospitals were full of very, very frightened individuals who didn't speak the language and didn't understand what they were supposed to do, and they were getting their information from overseas, and we just didn't have any engagement with them, and it was a real problem. So that's when we first started trialling these peer navigation roles. And Leash, who is Pacifica, she's on the right here, Pacifica Navigator, started a mothers group for Pacifica women, so Samoan, Niue, Maori, New Zealanders in Australia. And the very first group, so it was advertised through social networking and through her networks, and it was just turn up. You don't have to have an appointment, but if you turn up, there'll be a midwife there, you'll get some education, you'll have some peer support with other women that are pregnant, and I'll be there to support you as a navigator. And they are an essential part of these types of groups. And at the very first one of those sessions, we had a mother arrive who had no antenatal care at all. She was 24 weeks pregnant. She had 2 children at home. She'd been feeling really unwell, but and very, very tired, and thought it was just because she was pregnant and she was running around after toddlers. She was actually pregnant with twins, and she was in preeclampsia, and she ended up in our emergency department supported by Leash and is now engaged in the system. So you can see how really those alternative models of care, those peer navigators to bring people in is just essential. And I'm really excited to be part of the process, and I'm really excited to be partnering with Peter Mac on making this happen in the world of cancer. Thank you.
Thanks, Beck. So in the interest of time, I'm going to whip through because we want to have a bit of time for questions. So our patient experience strategy sets the scene for what our patients want us to be focusing on and investing in. And so for the last 5 years, every consultation we do, usually through our patient parliament, the number one issue is patients want us to help them navigate the system better. They want personalised information and communications. They want us to help build their own capacity to self-manage and also to care for their carers. So we have, as you've heard from Beck, our peer mentor program. And so they've had a number of training modules they've undertaken from the training program that Beck actually talked about, but also from the training program we developed when we developed a palliative care volunteer program. So at Peter Mac, we're focusing on head and neck and upper GI cancers. We have some bilingual navigators, so Indian, Taiwanese, Chinese and Croatian, and they can see people from any cancer stream. This is how you access the program. So what we want is we want our clinicians to refer their patients to our program. So to send them to the PAC service, Patient and Family and Carer Support Service, located next to Clinic 2D in the Information Hub. But you don't need to be a clinician to access the service. Patients can self-refer, but it's useful to have the clinician referring and understanding what the program's about. So far, just a couple of quotes there. You know, my mentor is awesome. He's a great resource and he's a calming balm with little texts of encouragement. Thanks for setting up the program. Meeting my mentor was exactly what I needed. Thank you. The staff are amazing here, but can only provide anecdotal evidence, whereas my mentor has lived it and come out the other side. So that's exactly what we were hoping to achieve, this program. And so I don't think I'll go into any further details because I do want to get to questions. I will say it was nice to see you acknowledge Dr. Harold Freeman. So I was the first Australian to do the patient navigation training program with him in 2018. And he'd be in his 90s now. He's an amazing man, a breast surgeon from New York. The other thing I would also like to acknowledge is our consumers that were involved in the co-design of the program. So we have a number of them here today, and we're so grateful to have our consumers guiding us in the development of our services. And also a special acknowledgement to G, one of our consumers from Northern Health who recently passed away. So we recognise the impact she's had, and we're so grateful to her and her family. So I'm going to invite the speakers up to have a seat and let's see if we've got any questions. Oh, there's some up here on Menti. So there's Menti. If you want to ask a question, use the QR code, or if you're in the room, put your hand up. So I'm going to take the first one. Do the peer navigators also support carers? Yes, they do. So one of the challenges we found is recruiting people from upper GI because they're often very unwell. So we kind of thought, well, let's look at carers. So someone who's cared for someone with upper GI, but we had our first match last week for one of our mentors, but certainly they can provide support for carers. And we've also got the Patient and Carer Support Service at Peter Mac, which is a drop-in service in the next to 2D. And the Carer Support Service you can access through the Wellbeing Centre, where we have a Carer Support Officer. It's the amazing Carmen, one of our nurses. And we have Karen and Ali, our two psychologists that can provide support for carers as well. So this is a question for Jackie. How do you control workload for the navigators? Can multiple patients match with them at one time?
Yes, so we leave it up to the navigator to determine their capacity. There's a feature we built into the app where they can indicate their preferred capacity and they can change it. They can turn it off if they're going on vacation or if they have other things going on. And we can also change it if they need our support to change it. So it really does vary. You'll have some individuals supporting one person at a time, and then you have other individuals who have been in the program for, gosh, a long time. And they can give one in particular, and he's easily got 5 to 10 on the go at any time. So it really depends on the individual and the amount of time they have to contribute to the role.
Okay, so how do we ensure that navigation focuses on those with most difficulties and have major needs, rather than navigation and support services getting to those who have the highest health literacy?
I'm wondering if Rebecca wants to, because that program that you're talking about, where you're identifying those with highest needs and then linking them, I think that those are the most needy and hardest to reach group.
It's a really, really good question, and one I don't have the perfect answer to. I think the one important aspect of this program is that it is, it recognises that individual consumers do have some agency, and they need to be part of the decision making about whether or not they engage with a peer mentor. And so it's actually recognising that it's more about making sure that we market to the right communities, that people know about the program, and then if they choose to engage, making sure that it is available to them. But we often talk about trying to work for the most marginalised, so the people sitting in the margins. If we can get it right for them and we can engage them, then everyone else will be able to have access. So that's really what we're trying to do, and I think we do that by identifying the most at risk. And there are some communities and there are some pockets of certainly cancer that are certainly more underserved than others, and I think that they're the ones that we're really trying to target at the moment, certainly with our peer navigation program with Peter Mac. But I don't have the perfect answer. I wish I did, because they are the people we want to engage with.
I mean, I guess the other thing is, it's quite a scalable project, so we can scale up and really focus on marginalised groups as well. We're doing a lot on with very little. I'm just going to throw this one question to Brett.
Wanted to add, if I could,
yep.
That partnering with community is really key. So we've partnered with the Walnut Foundation from the very beginning. They're an organization in Ontario and representing Canada that raises awareness for Black men's health, really focusing on prostate cancer. And so we partnered with them from the very beginning to design the program, engage members of the community to be navigators, and then they promote the service as part of their suite of services. So certainly found that to be quite helpful.
Thank you. So there's a few questions in the room, but I'm going to go to Brett for this question. What advice would you give to other cancer patients who are considering using peer navigation services?
It's pretty personal. Like I said in my talk, I don't know that it is for everyone. I think I was fascinated watching the clinicians thread the needle with how much information to give me. And as I slowly got to know some of them a little better, I could have a more frank conversation. And I also, there's no time for too many stories, but I also ran into a couple of people. I didn't meet them, but I overheard things I shouldn't have been overhearing downstairs, where people, I wonder if they'd had too much information. I wonder if they would have even proceeded with some of their care. And so I think we have to be guided by the patients themselves, because, I can't make an assessment, and neither can the clinicians, as to how much they need. And the clinicians get like 30 seconds to try and decide how much information do I give this patient, how much do they need genuinely, how much is too much. But I think if you leave that to the patient and whatever they're comfortable with, and I think if they're opposite someone like me or someone similar to me, I would like to think it's far less intimidating, particularly if you're not health literate, to ask those sort of questions
Mm.
and tiptoe your way through it.
Yeah.
Yeah. That's my gut feeling.
Great,
Anyway.
thank you. Tracy.
Thank you. Fantastic presentations and great initiative. Really enjoyed hearing all of that. Just a question. I'm interested in how the peer navigators or the navigators are supported to recognise and perhaps escalate any clinical issues that might be occurring, to make sure that people do get the care they need at the right time.
Yeah.
I'm not sure, Brett, you might have had the training,
Want
but
to take that one, Beck? Or Fee could respond to that actually.
Yeah, during the training and any conversations we have with the mentors, it's very much about if they feel there's anything at all in the conversation that's concerning, that they contact Peter or I, and during the weekend it's Jerry, to have those conversations with us, and then we'll refer them on to the nurse consultants if it's a medical concern, or escalate it further through to social work. So we have worked with the clinical nurse consultants, and their advice is no question is too small, just contact us straight away. So that's the understanding by the team and also the mentors.
Can I just quickly add to that?
Yeah.
So we have another peer navigation program we have at Northern Health has a much more structured decision support tool that the peer navigators use, and that it creates alerts. But I think for the work we're doing in the cancer space, it's a lot more organic and it's a lot more relationship based. And so we want it to be something that is less structured and has those, less of that guidance around very specific questioning, because we want it to be a relationship that develops over time. So what Fiona described is, we're seeing how that goes, and I think that is a really good model that could be applied in other areas if we, but we will be looking at whether or not we've had any issues or adverse events, or because I can see there's concerns. I know clinicians always have concerns about people working outside of boundary or not escalating when they should be escalating because they don't necessarily know they should be escalating. It's a tricky, because if you try to create too many scaffolds around the role, then you lose the personal.
Thanks, Beck. And I think this might have to be our last, so Kelly.
Thank you. I'm just wondering if there are any mechanisms built in for regular support or debriefing with the peer mentors, just thinking about their emotional safety and wellbeing.
Sure, I can talk about what we do in our program. So our role as the program team is to support the navigators. We convey to them from the very beginning, you're our number one focus. While we're here to support patients and caregivers going through the system, our job is to support you. And so we have monthly debriefing meetings that we hold virtually through Teams or Zoom, that are led by team members and then a clinician. And so during these monthly debriefings, we share we have case debriefings, we share the positives, the challenges, and work through them together. So there's a lot of peer learning. We also have one-on-one support provided as needed, but we're essentially always on and accessible for them. So we convey, if you've got any concerns, just reach out and we'll be there to support you. We also offer a continuing education program. So in addition to the initial training we offer, we alternate the peer navigator debriefing meetings with continuing education. So if there's topics that they want to learn more about, we'll develop some content on that or invite in an expert. And we also monitor their report documentation. So after every interaction, they have to complete a report within the secure system. And so we stay on track how things are going that way too.
So I'm sorry we haven't got to all the questions, but please do feel free to email Fiona or Peter or I if you want further information. We've got here our postcards. So if you take them up to the ward, back to your workplace. But I would like to ask you to thank our speakers for a really interesting, engaging session. And thank you to those online and who came up face to face. Enjoy your day.